Okay, so first thing we're going to start with is APGAR scoring on babies. So when a baby is born, every single baby that is born gets an APGAR score. It's based on 5 different things. So activity, pulse, grimace, respirations, and appearance. So depending on what the baby's doing depends on what their score is or what they look like. So every baby gets a score at 1 minute of life and 5 minutes of life. So typically, I know like when I go to delivery, we have a timer. So we hit start, it beeps at 1 minute so that I know, okay, look at the baby, what's the baby look like, kind of what's their activity, what's their pulse, just looking at everything, and then again at 5 minutes. If they have a score of less than 6 at 1 minute, they go 1, 5, and 10 minutes. If they have a score of less than 6 at 5 minutes, we do 1, 5, 10, and 15 minutes. Usually at 15 minutes we stop scoring. But if at 1 minute they look fine, at 5 minutes they look fine, then that's all we do. So activity. So if they have no activity, no tone, they're not doing a single thing, they get a 0 for that score. If they have flexed arms and legs and they're just kind of like flexed but not really doing a whole heck of a lot, then they get a 1. And if they're like actively moving everything, then they get a 2 for that category. The highest score you can get is 10. I don't think I've ever scored a 10 because babies always have, there's always something. Most time it's colored. Pulse, so we listen for a pulse right away. So if they don't have a heart rate at all, they get a 0. If they have a heart rate less than 100, but it's beating, then they get a 1. And if they have a heart rate of greater than 100, then they get a 2. Typically you'll know too when a baby first comes out, like you'll kind of know or have an idea of what their heart rate is. If they're completely limp, floppy, not doing anything, I can guarantee you their heart rate's not going to be greater than 100. So then for grimace, or also sometimes people will say like their reflex irritability. So if they're floppy and you like lift up their arm and it just drops, they get a 0. If you lift up their arm and they pull it in, but that's like all they do, they get a 1. And then if you lift up their arms or legs and they just keep kicking or moving their arms, then they get a 2. Appearance is the next thing. So blue or pale, which all babies come out blue because their circulation hasn't switched over from maternal to fetal or newborn. What would be some reasons? So the other point of this 0 score is pale. Why might a baby be pale when they come out? Like pale as white as your scrub top. Any ideas?
Respiratory problem?
That's usually blue. Typically blue. Blood, some type of blood loss. Yep, so could be mom had hemorrhage. Maybe she had a uterine hemorrhage. Or maybe, or uterine rupture, I guess. They also can have what's called maternal fetal transfusion, where for some unknown reason, the flow kind of reverses and mom's blood keeps all of baby's blood rather than that constant flow of giving baby blood as well. So those babies can be born very, very hypovolemic, have, low hemoglobins, need blood right away. So those are 2 things. So blue or pale for 0 points. If they are pink in their trunk, they get a 1. What if their extremities are still blue? Because they always starts with the vital organs first and then works its way out. The coloring will work its way out. And then if they're completely pink, then they get a 2, which I can tell you I've never given a baby completely pink because they 99% of the time have acrocyanosis of some kind. Their hands or the feet are blue in some way, shape, or form. Like, I can't say I've ever had a baby that's like just gloriously pink all over within 5 minutes. And then respiration. So if they're not breathing at all, they get a 0. If they have slow respirations or they like take a breath or 2 and then they stop, And they take another breath or two and stop. Then they get a 1. And if they're vigorous crying, they get a 2. So, like I said, every baby, 1 minute and 5 minutes. Also kind of helps us gauge what we're going to do for resuscitation. So every baby when they come out gets dried off and stimulated. So we want that baby to cry. We want that baby to kick and scream. Not all babies do that, and sometimes they need more support than what we can give them just by drying them off. So then we follow kind of like you follow BLS for adults or BCLS or whatever you call it. We follow neonatal resuscitation guidelines. So what is their heart rate? If their heart rate is low, maybe they need something to kind of help perk them up, get them going, kind of jumpstart them. Babies, we bag with either an ambu bag or like we call it a neo-T. It's just another way of resuscitating rather than like an actual ambu bag before we even move to compressions of any kind. So we typically, if you bag them, give a few breaths, their lungs expand, open up, push some of that fluid out. Usually that will help them get going a little bit better. Another thing that you can do to help with getting them kind of to where they need to be is suctioning. So we always suction with a bulb syringe at delivery to help get all that amniotic fluid out. Some babies swallow more or suck in more than others. Some moms have a lot of fluids, some don't have a lot of fluid. It just kind of depends. So what do we suction first? The mouth or the nose? The mouth. Why do we suction the mouth first?
You don't put the contents of the nose into the mouth.
Yeah, so because when a baby, so anytime a baby, you put something in the kid's mouth and they go, if you just have sucked their nose out, everything that's in their mouth, which is typically a lot more than that's in their nose, is going down right into their lungs. So then you're like behind the 8 ball already, and now you just made it worse. So we always suck out. Just think of the alphabet. M comes before N. So that's the easiest way to remember it. Suction with a bulb syringe, sometimes they need more suction than just the bulb syringe, and we'll suction with a suction catheter. So this is usually hooked up to wall suction. This is an 8 French. Occasionally we'll use a 10 French catheter, and then just go down the back of their mouth. Sometimes they just hold a bunch of secretions in the back of their throat, or they've swallowed a ton of amniotic fluid. Like later on, they're just barfing, and it's just fluid. Sometimes us that are trained can go down and put a suction catheter down, kind of like you would put an NG down, except you put it down their mouth into their belly and suck up all that gunk out of their belly. And that will usually help with them puking, or if they're a little tachypnic or something, they might just need that fluid released. So with suction catheters, you obviously don't want to just put it down into their belly until you can't go any further. You measure just like you would measure in an NG and an adult. So if you're going down the mouth, you measure from the corner of the mouth. If you're measuring from the nose, you measure from whichever side nair that you're going to be going down. You always measure from the mouth to the corner of the ear to the xiphoid process, which also is known as like halfway between the umbilicus and the nipple line. That way you know, okay, when I get to 18, I need to stop because that's in their belly. That's all the further we need to go. We don't want to like perf their bowel or anything with a catheter. Any questions on that? No? All right. So the other thing we can use at deliveries to kind of see how a baby is doing, maybe they're blue and they're just taking forever to get pink. We can put a pulse oximeter on. Where do we put a pulse oximeter on a brand new newborn baby?
Ear.
No.
Foot.
No.
Nose.
No. This one looks weird too, by the way. Put it on their wrist. Which wrist do we put it on? Right wrist. Yep, does anybody know why we put it on the right wrist? Pre-ductal and post-ductal, so pre-oxygenation, post-oxygenation. So you want the most highly oxygenated blood that you can monitor. So same thing as an adult, except we don't use the little shark thing, shark oximeter, because it's not going to fit. You're going to have their whole hand in there before you even get anything. But same thing, the red light goes on the bottom side of the wrist, and then you wrap it around. So like if I was using this one, most of the time they just are like long and skinny like this, and you just, like, let's say this was your light, you would just wrap it around the wrist like so. This one looks like it would wrap like so, maybe, something like that, to monitor their oxygenation. Now when they're fresh, they're slimy, they're goopy, they've got gunk all over them. So just really clean off, wipe off that wrist before you put the pulse oximeter on, or it's going to fall right off anyways, and you're not going to have a good reading. Or you'll have a reading and it'll be like 42% and the baby's peeing, and you're like, no, try again. So that's pulse oximetry. Babies also take immediately right after birth, can take several minutes for their oxygen saturations to be greater than 90%. So if you're ever, in a delivery or whatever, and somebody puts a pulse oximeter on, and the baby's like 3 minutes old and they're setting 65, don't freak out. That's normal. Like, can take up to 5 minutes for a baby to have oxygen saturations of greater than 90%. So, any questions with that? Okay. Swaddling a baby. So, I know many people have probably swaddled a baby before, but to appropriately swaddle a baby, you fold down a corner of your blanket, put your baby on the fold, obviously, and then you always go from the bottom up first. So developmentally, so it used to be, like when I took Big Brother for 6 years, it was always side, then up, then the other side. But development studies have shown that it's better to go up first because it gives the baby something more to push against, which mimics more of what it's like in the womb. They have something to push against. Because if they don't have those boundaries as a newborn, it's like they're constantly falling. Like if you've ever had the dream that you're falling, that's what they constantly feel like, because they have nothing to push against. They have nothing to go like what they're used to. So always go up first and then side to side. And you may have noticed that I left the arms out. You never want to swaddle a baby with their arms down like this by their side. I know a lot of people will do that, but for their brains, that's harmful to them. And not, just developmentally wise. Baby, just think when they're in utero, how are they always when they're on ultrasounds? Where are their arms? Their face. Their hands are always up here by their face, tucked in. So you want to make sure that you keep those arms up, tucked in by their face. Just helps their development, helps their brain. They have more control that way, and feel more like they have more safety that way. So never down, always up by their face. It doesn't have to be like their arms have to be completely out. You can swaddle so the blanket comes across the front of their arms. That's that. With, so now feeding, we'll move on to feeding, I guess. So there's a couple different ways to feed a baby, obviously. They can breastfeed, they can bottle feed. If they're in the NICU, sometimes they have NG feedings. Or if you have a pediatric patient, they might have a G-tube, depending on what diagnosis they may have. So for infants, though, when a baby is first born, the first day of life, their stomach can hold about the size of a shooter marble. So about 5 to 7 mLs of food. So when the mom says, oh my gosh, they only took 5 ml, like they didn't take anything. Well, that's all their bellies can hold. We may give a parent a bottle, a full bottle, and they may say, well, when do I make them stop? Well, if they've taken 10, make them stop, because most likely they're going to barf, and they're going to throw up everything they just ate anyways, or at least half of what they ate, because their stomach can only hold this much. Same with breastfeeding moms, you know, they're like, oh, well, I'm pumping, I'm getting like a drop. That's okay. That's completely normal. That colostrum will hold them over. They only need a couple drops. It's liquid gold, so if a mom is pumping and all she gets is literally a drop, never, ever wash that drop down the drain. Get a Q-tip and, you know, suck up the breast milk with a Q-tip, rub it on the insides of their cheek, the baby, let the baby suck on it. Never get rid of any drops of breast milk. Then by day 3 of life, they have a stomach about the size of a ping pong ball, so about 20-ish mLs. And then by the time they're day, it's like 7 to 10, they can tolerate up to the size of an egg, which is about 60, which is 2 ounces, because 1 ounce is 30. Most babies aren't going to be taking 2 ounces by 10 days of life. Some babies are, depending on how big they are. But it's just a good judgment. So you know, if you have a baby that is, only 12 hours old, you kind of have a guesstimate of how much they should be taking. So so let's say a mom plans on breastfeeding, but her baby's got, baby blood sugar issues or just needs more calories. We might supplement after they breastfeed with a bottle of either donor breast milk or formula, depending on what the parents want. What would be some indications or some babies that you think would need that supplementing?
More than a 10% weight loss.
So if they've had weight loss, what about initially, like within the first couple hours after being born?
Not sucking, not eating.
If they're not like truly getting anything, so our small for gestation age babies, so your preemies, or babies that maybe are full term but are just really small. You might have a full term baby that only weighs, 4 pounds or something because they had a growth restriction in utero, or maybe mom was a smoker or something, and they're just small, so they need more calories to keep themselves warm, to grow, to do everything they need to do. Also, the big babies, the large for gestational age babies. Why? Babies that are really, really big babies. Moms typically have what? Gestational diabetes. So what happens with babies when moms have gestational diabetes, or like what's happening there? Yep, so their body is so used to that high sugar that their bodies are constantly kicking out insulin. Well, now they've come out, we've cut that cord off, and they no longer have that sugar, but they still have insulin. So they're constantly, now their sugars are going to drop really fast. So those kids a lot of times will need extra food to keep their blood sugar up. If mom's just straight breastfeeding, not always, but most likely it's not going to cut it. They're going to need something else for additional calories to keep their blood sugar up. And that's the biggest thing with babies born to mothers that were gestationally diabetic, is watching their blood sugars really, really closely when they're eating. Okay, so feeding with a bottle. So a full-term, normal newborn in the newborn nursery is going to typically start with, a lot of times we start with formula. It's in like a little bottle like this. It's got the ml lines on the side so you can see how much the baby has taken. Or you can put, maybe mom wants, maybe it's a 35-weeker or something. They want donor breast milk, whatever. Put a volume feed. And then a newborn, or also known as a slow flow nipple, is what's on them. Now you have a preemie. Are they going to handle a slow flow newborn nipple very well? No. So they're going to typically use a preemie nipple. So there's different sizes. The size of the actual nipple itself does not change. It's the hole in the end of it that changes. So the smaller, so like on a preemie nipple, if you held a preemie nipple and a newborn up and like had them drip into a cup, the newborn one is going to drip a lot faster than the preemie one. The preemie one takes a lot longer to drip out. And that's so that they can have better control of all that, of the milk. So babies' brains, or their like natural development of suck, swallow, breathe, doing all of that together, doesn't actually develop until 35 weeks on average. So you may have a baby born at 35 weeks in the newborn nursery that looks fine otherwise, doesn't need the NICU, but they're going to struggle a little bit with feedings because they're trying to figure out, okay, I got to suck and then I got to swallow and then I have to breathe. They can't just suck, suck, suck and not breathe, but they will if you're not careful and watching them. So normal newborns, feed, just cradle, feed them. Preemies, you want to feed what we call elevated sidelines. So we kind of put them on their side up at an angle, and then we put the bottle also at an angle, so they're only getting milk out of here that they pull out. There's no milk like actually dripping in. And then you're going to reduce their risk of aspiration as well, because the milk is now dripping into their cheek and they control when they swallow it. Whereas you have a baby feeding like this, you know, you're like this and you drink this milk is constantly just going down the back of your throat, and they don't have the control to close off their airway, open up to let the milk through, to close that off. They don't have that response. So this gives them the ability to safely eat. There's all different kinds of bottles. It's very much parent preference on what they use. Sometimes if a baby has, you know, a lot of reflux or they're really gassy, they'll use a bottle with more of a vent system. I know in the NICU we use Dr. Brown bottles because they also vent a little bit more than some of the other bottles, but very much so parent preference. Unless they need a small, if they need a preemie nipple, then you have to use a bottle that can use a preemie nipple. As the child gets older, the nipple size needs to change. So if you're taking care of a pediatric patient who is 13 months old and still, you know, has a bottle but still has a newborn nipple, that's where you need to educate the parents that they need to move up in size. So there's different sizes, level 1, level 2, level 3, etc. for as they get older. Otherwise they're going to like suck, 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 suck and hardly get anything out, and they're going to be frustrated. Okay, so that is feeding. Didn't know there was so much to know about feeding, did you? With breastfeeding, there is obviously every woman is completely different. Milk supply doesn't come in typically until like 5 to 7-ish days. The initial, they're going to get that colostrum, which is exactly what they need. We want to get those moms pumping as soon as possible because every amount of stimulation to the breast is going to help their milk supply come in a lot faster. So if they have a preemie that's in the NICU, get them pumping right away. Yeah, they may not be able to feed their baby right now, but we can swab their cheek with it, with the drops. We can store the milk. We want to get them going as soon as possible. Moms that have very flat nipples, we want to, sometimes they'll issue what's called a nipple shield, and it'll give the baby something to actually latch onto. Because if a baby has nothing to actually latch onto, they can't draw that milk out. So what a nipple shield does is it's just like a small silicone thing with like a nipple on the end, just kind of like a bottle nipple, but it's got like multiple little holes on it, so the baby actually has something to suck and pull against to draw that milk out. So if your baby is having a lot of trouble, you know, is really frustrated, isn't latching, isn't eating well, and mom's getting frustrated, that could be something that can help them. All right, okay, that's all about feeding. Now we'll move on to, we already talked about pulse oximetry, blood pressure. So blood pressures in an infant, where do we take the blood pressure in an infant typically? Yep, usually the lower leg. So you always want to make sure you have the right size cuff, just like an adult. Any pediatric patient, you want to make sure you have the right size cuffs because they're all, you know, you may have a 5-year-old that weighs, I don't know, 40 pounds, and then you might have a 5-year-old that weighs 90 pounds. They're going to have a different size blood pressure cuff. Same with, you wouldn't put a bariatric cuff on me, and you wouldn't put a cuff that fits me on a bariatric patient. So same thing in kids. Infants, we typically take their blood pressure kind of around the lower part of their legs. So same, line up where your artery would be on the inner side of the leg, and then wrap your blood pressure cuff around. Once kids get older, I usually kind of go with the school age as kind of my cutoff for a lot of things. School age is when I'll start putting it on their upper arm when they kind of tolerate that a little bit more. Now some 3-year-olds will be like, yep, and they'll give you their arm no problem. Other 3-year-olds are going to rip it right off their arm. And so that's when you can put it on their leg, give them something to watch or something to distract them. Because if it's not up here, if they can't see it up here, they don't think about it. So then it's a lot easier to get a blood pressure. Now pediatric blood pressures, it's like 120/80, good, all ages, no. So how do we know it? Like, that would be, yep, you're right, that would be way too high. Yep, so your blood pressures are going to vary, your normal ranges are going to vary with the different age kids. And that's where I highly recommend, if you're on a peds floor, or you know, doing clinicals or whatever, have a little tip sheet. Like I have a little tip sheet on my badge reel that I still reference, because I'm like, okay, yeah, this kid's 4, yeah, that's, you know, that's right, or oh no, that's not at all, okay, you know, this kid needs something. An infant, like a brand new newborn, how we use, or like the kind of tool we use to know that a blood pressure is appropriate, is by using the mean arterial pressure. So the number that's in the parentheses behind it, you want that to at least be their gestational age. So if they're born at 40 weeks and they're a full-term baby, and you go and do their blood pressure, and it's like 40/15 with a map of like 22 or whatever, you know, whatever it would be, that's going to be a huge red flag. That baby's got something going on. So you always want it to be their gestational age. If it was, you know, 50 and the kid is a 40-weeker, that's perfect. You know, that's okay. Any questions on blood pressure cuffs? Okay. Did that. Did that. Did that. Okay, catheters. Everybody's favorite thing. So, what is the difference between a Foley catheter and a quick cath? It's a real hard question.
Foley stays in and then quick cath is your straight cath.
Yes, Foley stays in, the quick cath is just going to be your straight cath in and out. So your Foley size, again, pediatrics, everything is weight-based. It's not like an adult where it's one size fits all. So you always want to be careful and choose the appropriate size of catheter that you're going to be using for anything. Same with IVs. We don't ever put 18 gauge IVs in kids. Most of the time we do like 24s or 22 if we're like really need something big. But most of the time we'll just do 24 gauge. So this is a 6 French urinary catheter. This one, sometimes you'll see them with this little guide wire in it. Not all of them will have a guide wire, so don't be surprised if you go to put a Foley in a kiddo and there isn't a guide wire, because there isn't always. But always make sure you take that out once you have the catheter in. Same with the balloon on the ends. Same exact thing. You're going to inflate the balloon based on the amount that it has on the actual catheter itself. So adults will say, you know, 10 cc's or whatever. You know, a pediatric one, it might only be 2 mLs is all you need to inflate that balloon, or you'll rupture it. Same thing when you take them out. Deflate the balloon before you take them out. Sterile, put them in the exact same as adults. Quick caths. We can use if we just need a very clean urine sample. So let's say, a kid comes in, you've got maybe a 20-month-old who's got a fever. They ruled out that it's viral, so this kid's got an infection somewhere, but where is it coming from? But we don't want to do an LP or lumbar puncture on them quite yet, because we want to make sure we exhaust everything else before we do something invasive like that. So a lot of times they'll ask for a cath urine sample, just like you would do on an adult. You can use the quick cath kits. Again, depending on the age of the child, be careful on what size French catheter you use. So if it's an infant, you're going to more than likely, like we use a 5 French feeding tube, which basically is kind of like this. It's just like floppy like these. And then we put the end of this in a sterile specimen cup. So it's always obviously more than one person doing the cath. But otherwise, most of your like school age kids or preschool on will be okay with this. This is an 8 French. You have your betadine swabs in here. Always use the lubricating jelly that's provided in there because it's sterile. Sterile gloves. Sometimes kids will just pee around it, so as soon as you get the catheter in, sometimes they'll pee around it. That's very, very common. But just get as much as you need for a sample, and then, I don't know if you've ever seen these, but these just come out, and this closes. And then you can label it and send it to lab. The other one that goes in the specimen cup, we just put the lid on it and send it down. Every facility is different. I know we have some they look like lab tubes that hook onto like a draw kit thing that sucks the urine out into this tube that we send them down in. So every place is a little different. What's another way we could get a urine on a kid? That's in diapers. Sorry, not a child that's potty trained.
They have bags.
Bag urines, yes. So if kids potty trained, obviously we can put them on the potty, teach the parents how to clean appropriately before they urinate. But if they are still in diapers, then we typically use a U-bag. Boys are a lot easier than girls, obviously, just like everything with that. But they've got the little stickies on it, so you always want to place your top stickies on first, and then a little trick so that your urine goes where it's supposed to is before you peel this back and put the sticky stuff on the bottom side, stick a cotton ball right here on the corner of this and then stick it down. It'll help catch any urine from spilling down, just down into the diaper. The other thing you want to be really careful of when you are putting one of these on is that you are very cognizant of where the rectum is so that you're not covering it with this sticky stuff, because you want them to still be able to stool if they need to. Sometimes it just leaks everywhere and you have to try 2 or 3 bags before it actually works. But we literally just just wad it up in the diaper and wait until they pee to get your sample. When you take off, same with anything, tape you take off, just like a geriatric patient, always be careful of their skin. Use an adhesive remover or like a saline. We have like little saline wipes that you can use to get it off so that you're not ripping their skin, because that would be ouchy. A lot of them have like a spot where you can draw back your urine out of the bag, because typically there's not always a ton. It is kind of like a one-way ticket, so once the urine gets down in here, it can't come back out the top. Usually I'll just take you can use sterile scissors and cut the corner and empty it in a bag, or you can stick a blunt tip in there to draw back your urine to send down to lab. So that is all on bagged urines. There was something else I was just thinking of that I was going to tell you about, but I can't remember what it was. Something with, I know what it was. Bagging. Where did my iron board go? Arm boards for IVs. So obviously peds patients are not always, they're not going to just see an IV and leave it alone. And a lot of times it's hard to tell them to keep, you can't just tell them to keep their arm straight because that's not going to work. So a lot of times we'll use arm boards. Where can we put IVs in kids?
The head, foot,
The head. Where else?
the hands,
The hand. Where else?
the foot.
Foot. That's the most of them. Hands, head, foot. They can do IOs if it's absolutely necessary, just like in adults. Typically, though, we try for hands first, and all babies or, I mean, really any peds kid, I'll try a hand first before AC, just because they're constantly bending their arm, and then it's constantly alarming and upsetting the parents and the patient. So we try for hands if we can. We'll do scalp veins in the NICU or any real small newborn. Typically, you do have arteries in your head too, so you have to be careful that you don't hit an artery. Or does anybody know if you go to start an IV and you accidentally have hit an artery? Do you know how you know? Not bleed. I mean, they'll bleed better, but there's another classic sign. When you flush, it'll blanch, so the skin will turn white. So normally when you flush, you don't notice anything different with the skin. If you accidentally hit an artery, which does happen, it turns white right away, and you can tell. So then you have to take that out right away. But otherwise, like I said, hands. Then we'll put an arm board on, so it's always the firm side down and the soft side towards their skin. We'll kind of